Register publication that you see there was out, and then we could actually do this. We could teach these courses the right way. But it was very frustrating. For 30 years, this was the worldwide standard of care. We just couldn't talk about it. So, what we have today is a far better appreciation for anatomy and its variations. We have much more refined and purpose-built implants to take advantage of that anatomic understanding. We're empowered to tackle bigger, tougher problems. Things that were deemed just simply inoperable back in the 80s are now commonplace operations. But you can't forget the fusion. You have to get that part right. So an example of one of these that sort of ties all of these little tips and tricks together. This is a patient with severe upper neck pain as well as progressive myelopathy. If you take a look at the upper cervical spine, not only does this patient have the obvious stuff going on with the stenosis, which also happens to have severe atlantoaxial arthritis, which is often overlooked on MR, but much easier to see on a CAT scan. So what she ended up needing was a decompression and fusion from C1 to her thoracic spine. On your left, you see a normal atlantoaxial joint. On the right, a severely arthritic one. You see a difference in the anatomy and location of the vertebral artery, which has implications for how you would try to do this. And if you think about all those slides I showed you, there's a transarticular screw on one side, there's a C1 and C2 screw on the other side, subaxial purchase in the lateral mass, thoracic pedicle screws. It sort of ties all of those things together in one case. So let me sort of pause there and take questions, comments, queries, criticisms.
So John, the older techniques, the wiring and the wiring long plates of bone graft and or wiring into a piece of anatomy because that's all we had back then. Does that inform any, or do you do any of those techniques today in combination with some of the new stuff like you showed?
Okay, everybody hear that? Okay, the question was, is there still a place for wire in this? And I would say maybe. It depends on context, right? If you're operating in an environment where you have to be very budget conscious, and you can imagine there are places in the world where that is an absolute necessity. Sometimes just for fun, just to be different. If I'm doing a case at Grady, our trauma hospital, and let's say it's a C5-6 ligament injury that needs a one-segment posterior fusion. Yes, you can get out the fancy kit with the 4 screws and the little rods and all that kind of stuff. Anybody have any idea what that costs? Give me a guess. What does one of those little screws cost?
$2,000 a screw.
Actually, it's about $2,000 for maybe for the whole. Most contracts, your institution probably gets a discount, so you might be paying $400 or $500 a screw, and then whatever they charge you for the rod. So if you're in an environment where a lot of indigent care, a lot of unreimbursed care, that's an expensive operation. On the other hand, you can get out the small frag set, take a 5-hole plate, cut it with a burr, and use 4 3.5 cortical screws and do exactly the same operation. That's what we would have done in the late 80s and early 90s. And that's a much cheaper way of solving the same problem. And in the typical trauma victim with young, healthy bone, it works fine for, $50. So there are times that you can do that, and if you want, add interspinous wiring to it. In young, healthy bone, it tends to be very acceptable. It's more of a problem if you have a patient who is going to be non-compliant. not that those ever show up at a trauma center, or a patient who's a quad who needs to go to rehab, and they're going to be highly dependent on moving their head and neck around. They'll tear that apart. So you want to do something more definitive for them. But for somebody who just needs a pretty basic fusion, you could use wire today. It'd be a little hard to find it. You'd probably be using the braided titanium cable, which, oh, by the way, costs about $1,000 undiscounted, so you're not really saving a lot of money there. But I sort of challenge the residents and fellows to think about cost, because it matters. You know, if you've got essentially an indigent hospital, you need to save the money for where you really have to spend it on implants that have no alternatives. Any other thoughts, questions?
So what do you tell your patients, the average 65-year-old patient in Atlanta, the likelihood of fusion rates are now for each of those major segments we talked about? Are they up plus 90+%?
Let's sort of start. If for a C1-2 fusion using current techniques, if you're using iliac crest autograft, the fusion rate should be about 95%. You might give that a little bit of a discount for somebody who's on various drugs to control their rheumatoid arthritis or something, but it ought to be in the mid-90s. If you do the biology and preparation correctly for things like a laminectomy and fusion, your fusion rates should be in the mid-90s. If you cut corners, if you're less rigorous in your choice of bone grafting method, you can compromise those fusion rates down to less than 50% easily. I would urge you, whenever you're out there making decisions after leaving training, think carefully about what a representative is bringing to you as a proposed alternative to traditional bone grafting techniques. Ask them for the data. You know, a lot of the DBMs and stuff that are out there, there's no clinical data. They're not even animal data to show that they have any osteoinductive capability at all. The cellular products that are represented as being bone graft substitutes, ask to see the data. Demand to see the data before you decide whether you're going to use it in a patient or not. Yeah?
So how often are you using autograft then? You've mentioned this a couple times, you do this most of the time?
For posterior cervical, it would be the exception for me not to use autograft. And off-label comment, if it's a situation where I prefer not to harvest iliac crest graft, I will use a combination of local autograft with BMP, but that's an off-label application and kind of needs to be thoughtfully used too because of the expense and what the hospital has to absorb. But it works. Okay. So thank you, and in 1988, when I was a fellow, Dr. Garfin was nice enough to say, we treat the fellows to one course and one meeting. Okay, the fellow, right? I was one guy. And so there was a cadaver course in Toledo, Ohio. And any of you, given the opportunity to go to Toledo, Ohio, are gonna jump at the opportunity, right? So off I went. Turned out it was actually a really good idea because this was the first time that Raymond Roy Camille had come to the US to do one of these cadaver labs with his friend, who, Dr. Ibrahim, who was the head of trauma at Toledo. And basically there were a handful of us who spent 2 days working on cadavers with him and some of his younger disciples, learning all about screws. You have to understand, in the late 1980s, we were still just starting to learn how to use pedicle screws in the lumbar spine. So this was totally virgin territory. Never seen anything like it. Maybe in a journal article you've read about it because he and Moggerel had published some stuff by then. But this was a fantastic, eye-opening experience. So I sort of took that back to San Diego. Then when I was hired at Emory by Tom Whitesides, Whitesides told a story about being a resident at Wash U, and they had this young Japanese postdoc come visit. And at the time, Whitesides had just been assigned by the Air Force to go to Japan after his residency. So the chairman at Wash U said, Whitesides, I want you to look after this guy Kashiwagi, show him around, make sure he gets where he needs to go, you know, just take care of him. Well, that turned out to be a very important relationship. At the end of World War II, Kashiwagi decided that Japan needed to sort of reconnect with the world of orthopedics. So he started traveling fellowships. The idea was for Japanese to get out around the world and meet their colleagues in orthopedic surgery, learn from them, and try to bring those relationships and bring that knowledge back to Japan. So historically, the traveling fellowship concept actually started with Kashiwagi. Today, there are standing opportunities that occur on a regular basis. In the US, the AOA, the American Orthopaedic Association, has these regularly recurring fellowship opportunities. The big daddy of them all is the ABC Fellowship. That's by far the most prestigious and the most competitive. But you think of a group of people selected from North America and from the former British colonies that travel together for, I think, 6 weeks in one region of the world or another, to get to know each other and to be connected with the leadership of orthopedics in essentially the English-speaking world. The North American Traveling Fellowship, I'm sure over time you guys have hosted them here. That happens with half a dozen people from North America who then travel in one of 3 regions of the United States, again for the same purpose, to get to know each other, to be connected with the leadership in academic institutions in our country. The ASG Fellowship, Austria, Swiss, Germany, it's a reciprocal thing. Every other year we send a group there, then they send a group here. The same with what is now known as the JOA Fellowship, used to be known as the Kashiwagi Suzuki Fellowship. Specialty societies have them. Every special society is probably going to have some form of a traveling fellowship. A few years ago, we sort of reconfigured the one for the Cervical Spine Research Society so that it modeled more like the ABC. So every other year, 2 people from the Asia Pacific region, 2 people from Europe, and 2 people from North America travel as a group of 6 to one of the 3 regions of the world. They just wrapped up the 6 of them traveling through the Far East about 2 months ago. And the cycle will start again with the next group traveling in North America in 2 years. So this is Abubi in the operating room in 1996. Turns out I was the first Westerner to go to the operating room with him. Here he is 2 months ago. We're both a little older. This guy, Fujimoto, when I was in Hiroshima as a traveling fellow, I sat down next to him, and he was holding a couple of reprints. Turns out his interest in lateral mass fixation and mine were very much overlapping. We both had very common passions about where we were going with our research and stuff. And we've had collaborations back and forth. We've now had fellows from Hiroshima University a number of different times. He also happens to be a very good guitar player and a Beatles fanatic. He loves to sing, and every year at the Asia Pacific Cervical Spine Research Society, there are a bunch of guys who put on a little musical performance, and it always includes Fujimoto singing some Beatles songs. Anybody recognize that structure? So that's the A-bomb dome. Hiroshima is a very powerful place. So if you had the opportunity, I would recommend, if it fits into your career plans, look at one of the opportunities as a traveling fellow. Chances to develop lifelong friendships and colleagues. It'll open your eyes to different ways to treat patients. In the case of our department, it led to tremendous personal, departmental, and scientific collaborations. It was the beginning of the opportunity for us to host international research fellows going back to 1997, which in the case of Dr. Bowden's lab and Dr. Yoon's lab and others were tremendously productive, both from our side and from theirs. A number of those people are now either department chairs or division chiefs in their universities back home, and it was transformative. So, thank you. Any questions? Daryl promises me that the department would be very supportive of any young faculty who want to do this.
It's true. Or old faculty. Anybody wants
So most of these opportunities are sort of available to you between 5 and 15 years out of training. So it's at a time in your life as a young faculty member where you're probably in the very best position to absorb new techniques by just watching. You can learn a tremendous amount in a very short period of time. You know, you've spent about half a dozen years practicing your skills, getting comfortable with what you're doing, and it's a great time to sort of open your mind. It can be difficult because it's often a time in life when you have kids and practice is going well, but it can easily be 3 or 4 weeks very well spent. Yes?
There's one more alternative, which is you can find somebody you want to go visit, arrange to do that, and spend 3 or 4 days with somebody. You'll learn a lot, and you probably will cement a relationship. And so if you can't afford 6 weeks, taking a week and doing that can be really, really helpful, I think.
Yeah.
Thank you very much for sharing your experience. So I'm still at the very beginning of my career, and 2009, 2010, I did my research fellowship here at the University of Jura, came from Switzerland. And I realized many younger colleagues are afraid to do such fellowship because they think, well, I will lose a year of my career, so I will be behind. Actually, I had the same fear too before I came here, because I came just for research fellowship. I was not treating any patients. And I would say this is probably the most valuable time of my working career, spending a year here. So what is your thoughts about this? When you go for a fellowship abroad, your own clinic.
I agree with you, and it depends on what your career ambitions are and what your local circumstances are. The academic environment that I'm more familiar with would be in Japan, Korea, China, those areas. Those are intensely competitive environments where any opportunity to get a leg up in a very pyramidal promotional scheme is highly valued. And publications matter in very important ways. So for somebody who's early in their career as a faculty member in those countries, to leave their university, come to an institution either in the States or in Europe, work hard, publish 2, 3, 4, half a dozen papers if they're really productive, when they go back, they're going to be first in line for promotion to that next available associate professor position, which are precious few. So for them, it has tremendous practical value above and beyond the intellectual and cultural value. But as you can probably attest, it takes a lot of courage to do it, because you're leaving behind the familiar, and depending on how big a cultural difference it is, it's going to be a greater or lesser adjustment. But you can imagine if you're going to a place where it's not your primary language, it's not your familiar culture, there can be some real challenging adjustments to be made. Certainly for someone from Asia to come to the US for a year or two. Probably a little less of a difference from Western Europe to here, but as you can probably attest, it probably wasn't easy for the first few months. But I agree, as you said, it's a powerful opportunity. The good news, you're welcome. Thank you.